Ever heard of a microscopic invader that can make its home right inside your brain? Causes everything from seizures to, well, fluid buildup. And here's the real kicker. Treating it can sometimes make things worse before they get better. It sounds like something pulled straight from a medical thriller, doesn't it?
It really does.
Today, we're taking a deep dive into your sources on Neurocysticercosis, or NCC. We're going to uncover the surprising truths about how this condition shows up, how doctors actually figure it out, and the incredibly nuanced ways they approach treatment.
Yeah.
This isn't just about spitting facts. It's really about understanding a super complex medical puzzle. Okay, let's unpack this.
What's truly remarkable about NCC, I think, is how a seemingly straightforward parasitic infection, it demands such precise detective work in diagnosis and these incredibly delicate treatment strategies.
Right.
It really highlights the body's often unpredictable responses to foreign invaders.
Okay, so let's start with the basics for anyone new to this. What exactly is neurocysticercosis at its core? And what's so surprising about how it takes hold?
Well, at its heart, NCC is an infection. It's caused by the larval stage of a tapeworm, specifically Taenia solium.
A tapeworm larva? Okay.
Yeah. And what's truly surprising and frankly a bit unsettling is its latency. You could have this silent invader in your brain for years.
Years.
Even decades, potentially, without a single clue. Imagine the shock of finding out, a parasitic tapeworm's been a resident in your system because of this incredibly long latent period, often after exposure from something pretty simple like consuming undercooked pork or even just food contaminated with tapeworm eggs.
That's like a medical time bomb taken away, isn't it?
Very much, yeah.
So when this silent invader finally decides to make its presence known, what are the first big signs that something's wrong?
So when symptoms do eventually pop up, the most common things we see are seizures, and these can range mild to severe, and also signs of increased pressure inside the skull. Often that's from fluid buildup in the brain, hydrocephalus.
Okay.
Those are usually the first red flags that make someone say, okay, we need to look deeper.
Given that potentially decades-long hidden period, how on earth do doctors pinpoint something so elusive? What kind of diagnostic tools are they actually using?
It really is a detective challenge. The most definitive test, the gold standard for confirming it, is something called an EITB.
EITB?
Yeah, enzyme-linked immunoelectrotransfer blood. It's a bit of a mouthful. But interestingly, blood samples, serum, tend to be more effective for this specific test than samples from the cerebrospinal fluid, the CSF.
Okay, so a blood test can be key.
It can be, yeah. But beyond that, imaging is absolutely crucial. Now, for the older calcified lesions, basically, the parasite's inactive remnants, a CT scan is often preferred.
Right, the dead ones.
Exactly. But for the viable active cysts, and also for finding NCC in other parts of the body, not just the brain, an MRI is far superior. There's even a specific MRI technique, it's called a FLAIR sequence, that's especially good at revealing the Scolex.
The Scolex, that's the actual head.
That's the one, the head of the parasite. And a FLAIR also shows any associated swelling or edema around it.
Wow. The actual head of the parasite.
Yeah.
That sounds like the smoking gun you mentioned. Can you describe what doctors are looking for on a scan when they spot it?
Absolutely. So the Scolex, it typically shows up as this tiny nodule, maybe 1 to 2 millimeters in size, usually round or slightly elongated, and it's sitting within the cyst itself.
Inside the cyst?
Inside the cyst. On a CT scan or a standard T1-weighted MRI, it often looks, density-wise, similar to the brain tissue around it, maybe just a little bit denser. But here's the key thing. Spotting that Scolex, that's diagnostic. It confirms the NCC diagnosis. And this brings up an important point. How vital is it to distinguish NCC from other conditions? Because sometimes other neurological issues can kind of mimic its appearance.
Right, like what?
Well, for instance, lesions in the brain tissue that are bigger than, say, 20 millimeters, or have irregular edges, or maybe they're causing a significant shift in the brain's structure. Those are generally not typical for NCC.
Ah, I see.
Also, if a patient has broader symptoms, think fevers, night sweats, unexplained weight loss, swollen lymph nodes that usually points away from NCC and towards other systemic illnesses.
That makes perfect sense. So knowing what it isn't is just as crucial for getting the diagnosis right. Okay, so once a doctor suspects NCC, are they looking for just one type of infection? You mentioned forms of NCC. What does that mean for a patient? How varied can this condition actually be?
That's a great question because NCC is anything but monolithic. It really presents in several distinct forms, and each has very different implications for the patient's health and treatment. We generally classify them into sort of milder and more severe types. For instance, parenchymal NCC, that's where the cysts are within the brain tissue itself. That's usually considered milder.
In the brain tissue?
Right. This can include what's called a single enhancing lesion, which is typically just one solitary cyst, or you might see multiple active cysts. Then there's also calcified NCC. This means the cysts have died and calcified, basically turned into little scars, and this form is strongly linked to chronic epilepsy.
So it's not just that the parasite is there, but where it decides to set up shop that really dictates how serious the disease gets.
Precisely. Exactly. The really severe disease typically happens when the parasite gets into the brain's fluid-filled chambers. We call this the ventricles. That's ventricular NCC.
Okay.
This can actually block the flow of cerebrospinal fluid, causing hydrocephalus, that dangerous pressure buildup inside the skull.
Right, the fluid buildup.
Yeah. Or if it infects the space around the brain and spinal cord, the subarachnoid space, that's subarachnoid NCC, that can cause a really serious inflammation of the brain's lining, kind of like a severe meningitis.
Wow.
And here's a critical principle. If a patient has multiple forms, maybe cysts in the tissue and in the ventricles, the treatment strategy is always based on managing the most severe form present.
Got it. Go after the biggest threat first.
Exactly. It's also crucial to perform a comprehensive classification of NCC patients. We need to look for active lesions in the brain tissue, viable cysts, any ventricular or subarachnoid disease, and even check if it's spread to the spinal cord or eyes.
So it could be in multiple places at once.
Absolutely, which is why a full MRI of the brain is often needed to locate every single one. And interestingly, there's a strong connection between subarachnoid NCC at the base of the brain and asymptomatic spinal NCC.
Asymptomatic, so you wouldn't even know it's in your spine.
Often, no. The patient won't feel anything specific in their spine, but because of that link, we'll still recommend an MRI of the spine if subarachnoid NCC is suspected, just to be sure.
That's a lot to keep track of. So, okay, before doctors even think about starting treatment for a disease this complex, what are the vital preparatory steps?
Yeah.
Why is this careful groundwork so crucial?
It's absolutely vital, and for a very important reason. The medications often used in NCC treatment, especially anti-inflammatories and corticosteroids,
Steroids.
right, they can actually make patients vulnerable to other infections, what we call opportunistic infections.
Ah, okay, so the treatment itself opens a door.
It can, yeah. So before starting, it's essential to screen for things like latent tuberculosis and also an infection called strongyloids.
Strongyloids.
It's another type of parasite, a roundworm, and this is especially true if steroids are going to be used for more than a month because strongyloids is often found in the same parts of the world as the tapeworm that causes NCC. They're often co-endemic. So, to prevent a potentially dangerous strongyloids hyperinfection, doctors might test stool samples, do blood tests, or sometimes just empirically treat with a medication like ivermectin.
Okay, cover the bases.
Exactly. And one more crucial step, an eye exam. Specifically, a fundoscopy, looking at the back of the eye. This is always recommended.
Why the eye exam?
Two main reasons. First, to check for any signs of raised pressure behind the eyes, which can indicate pressure in the brain. And second, to rule out NCC within the eye itself. Because if there's a cyst in the eye and we treat it with antiparasitics, the inflammation could cause blindness.
Blindness, wow. Okay, so checking the eyes is critical.
Absolutely critical. Specialized eye doctors often use what's called indirect fundoscopy, which gives a better view, or sometimes an ocular ultrasound.
Okay, now let's get to the treatment itself, because this is where it gets really counterintuitive, like you said. You'd think the goal would be just zap the parasite as quickly as possible, right? But it's not that simple, is it? It's almost a paradox.
It truly is a paradox. The absolute priority, especially for initial and emergency management, is actually symptomatic therapy.
Managing the symptoms first.
Yes. Addressing the seizures or the pressure in the head. Antiparasitic treatment, while obviously essential for the long-term cure, is never an emergency.
Never an emergency. Okay, why not?
Well, the reason for this caution is that when the antiparasitic drugs kill the parasites, they can trigger this massive inflammatory response in the brain. The cysts basically rupture, release their contents.
And the brain reacts badly.
Exactly. Imagine your brain swelling up from the very medication that's meant to heal it. It can be really dangerous.
Yeah.
This is why corticosteroids, those powerful anti-inflammatory drugs, must always be used alongside antiparasitic therapy. Always.
So you need the steroids to calm things down while the other drugs kill the parasite.
Precisely. You would never, ever use antiparasitic drugs alone. But you can use corticosteroids by themselves if you need to control inflammation first. And critically, antiparasitic therapy should not be started until any significant pressure inside the skull or widespread brain swelling, that cerebral edema, has been brought under control.
That's a profound balancing act. Wow. So understanding this really delicate dance, how do doctors precisely tailor the treatment based on the specific form of NCC a patient actually has?
Precision truly is paramount here. It really depends on what you find. So for patients with viable cysts just in the brain tissue, the parenchyma, and assuming there's no increased pressure.
Okay, the milder form you mentioned.
Generally, yes. The approach changes based on the number of cysts. If there are just 1 or 2 active cysts, they might use monotherapy, just one specific medication, like albendazole, usually for about 10 days.
Albendazole?
Yep. And it's always taken with food, especially fatty meals, because that helps the body absorb it much better.
Good tip.
But if there are more than 2 active cysts, doctors often go for combination therapy. Usually albendazole plus another drug called praziquantel, again for about 10 days.
Okay, double drugs for more cysts.
Right. And in both these scenarios, remember, corticosteroids are given simultaneously to manage that potential inflammation. And of course, anti-epileptic drugs if seizures are happening.
Always with the steroids and seizure meds if needed. Got it. And what about the other forms you mentioned, like the less active ones or the more severe ones?
Good question. For a single enhancing lesion, that solitary cyst causing inflammation, albendazole is given maybe for 1 to 2 weeks. Again, always with corticosteroids and anti-seizure medication if needed.
Okay.
Now, for the calcified lesions, remember, these are the inactive scarred remnants.
Right, the dead ones.
Exactly. Anti-parasitic treatment is not recommended. There are no viable parasites left to kill. So here, the focus is solely on managing the epilepsy with anti-epileptic drugs. Corticosteroids are typically not used routinely here.
Just manage the seizures.
Pretty much. And then for the really severe cases, like something called cysticercal encephalitis, where there's widespread brain swelling, well, in that case, antiparasitic drugs are actually avoided altogether, at least initially.
Avoided, even though there are parasites.
Yes, because the risk of worsening the swelling is too high. The primary treatment there is high-dose corticosteroids to aggressively reduce that dangerous swelling first.
Wow. Okay, it's clear medication is key for many situations, but what about when direct surgical intervention becomes the only option? When do doctors actually have to go in and remove the problem directly?
Surgery becomes absolutely essential in specific scenarios. Number 1, if the parasite is inside the brain's fluid-filled chambers, the ventricles that are intraventricular NCC,
right,
that always requires a surgical approach. Antiparasitic drugs just don't work well there and can worsen things.
So you have to physically take it out.
You have to remove it or create a pathway for the fluid. Now, sometimes you have cysts that are kind of stuck to important brain structures, making removal really risky or not feasible. In those cases, the first step is often to divert the cerebrospinal fluid, maybe with a VP shunt.
This shunt to drain the fluid?
Exactly. Relieve the pressure first. Only after that pressure is managed do doctors consider antiparasitic therapy, and it's crucial not to start antiparasitics before surgery in these cases because the inflammation could cause even more fluid buildup, more hydrocephalus.
Timing is everything again.
Absolutely.
And what about those tricky subarachnoid forms, where it's in the space around the brain, or the ocular forms in the eye?
Right. For subarachnoid NCC, the initial focus, again, is often managing hydrocephalus if it's present, usually with that VP shunt. Then, antiparasitic therapy follows. But these subarachnoid cysts can be particularly stubborn.
Harder to treat.
Yeah, they often don't respond well to standard doses or durations of medication, so you might need prolonged courses of albendazole, sometimes combination therapy with praziquantel, and always with those corticosteroids alongside.
Okay, a longer fight for those ones.
Definitely. Now, for intraocular NCC, when the parasite is in the eye...
You said surgery for that.
Always surgery. It's non-negotiable. Because, as we mentioned, using antiparasitic drugs here could cause so much inflammation it leads to permanent blindness. You have to get the cyst out surgically.
Makes sense.
However, if the parasite is just in other parts of the eye structure or around the eye, what we call extraocular NCC, that can sometimes be managed with medication carefully.
This sounds like an incredibly intense, carefully choreographed treatment process.
Yeah.
What are healthcare providers watching for during and after these complex treatments? What are the flags?
Yeah, there's a lot of monitoring. During treatment, especially with medications like albendazole, first, remember the food thing. Give it with food, especially fatty meals, because it's poorly absorbed otherwise.
Right, better absorption.
And if the therapy lasts longer than, say, 2 weeks, patients need to be monitored closely for potential side effects like liver damage, hepatotoxicity, or a drop in their white blood cell count leukopenia.
How often?
Usually weekly checks of their liver function tests, LFTs, and complete blood count, CBC.
Okay.
If there are signs of drug-induced liver injury, for example, really low white blood cells, or liver enzymes shooting up, like more than 5 times the normal limit, the medication has to be stopped.
Just stop it cold.
Yeah, withhold it until those lab tests normalize. And at that point, doctors would have to consider alternatives, maybe switching to praziquantel if appropriate, or even deciding against further antiparasitic treatment if the risks seem too high.
What about the combo therapy? More monitoring.
Interestingly, for the combination therapy with albendazole and praziquantel, the monitoring isn't really much different than for albendazole alone. You still do the LFTs and CBCs.
Okay.
And finally, for patients who might need corticosteroids for a long time, because long-term steroid use has its own set of problems.
Right, side effects.
Exactly. There are strategies to reduce steroid dependency. Sometimes a medication called methotrexate can be used as a steroid-sparing agent. You start at a low weekly dose, maybe increase it gradually, while still keeping a close eye on blood counts and kidney function.
Trying to minimize the steroid impact long term.
That's the goal, yeah.
Wow. This has been an incredibly insightful exploration. I mean, truly fascinating. So what does this all mean for us, really? We've peeled back the layers on neurocysticercosis from its surprising ability to hide for years to the real detective work doctors do to diagnose it, the many forms it can take, and those incredibly precise, often really counterintuitive treatment protocols. It's just such a powerful example of how deep, nuanced understanding is absolutely vital in medicine.
Yeah, absolutely. And if we connect this to the bigger picture, I think this deep dive truly underscores how even a seemingly, straightforward parasitic infection can present with such intricate challenges.
Yeah.
It really demands a multifaceted and incredibly careful, considered approach to both diagnosis and treatment, where timing and combinations and managing side effects, it's literally everything.
Imagine the sheer precision and knowledge required to navigate a disease where the very cure itself can be a risk, right? And every single decision is this delicate balance between fighting the infection and protecting the patient's brain. It really makes you wonder, doesn't it, what other hidden conditions might be out there with equally surprising complexities just waiting to be uncovered?
It's a great question.
Thank you so much for joining us on this deep dive.